Neurology is a very clinical specialty, and it really benefits from neurologists keeping in touch with what's called general neurology. Mm-hmm. That's the ability to see, recognize, manage and treat people with any form of neurological condition. So movement disorders is or encompasses a group of conditions, things like Parkinson's, tremor, dystonia, and other types of problem where primarily the brain's control of movement goes wrong.
Yes.
So I have expertise in being able to diagnose that and treat it appropriately depending on the condition. And within the realm of neurology over the last 20 years, I've seen a huge movement towards a much more multidisciplinary approach to seeing people, patients, and treating them. And it's this very collaborative approach that helps us to learn, to develop, and to sort of provide the very best care for our patients.
Thank you very much, Tabish Saifee, for coming along today. You are a consultant neurologist in the movement disorder team here in Queen Square. First of all, I'd just like to ask you, how did you get here? Where was the journey? What's the journey for you?
That's a long journey. I mean, my time at Queen Square first began about 20 years ago. As a junior doctor. I was particularly interested in neurology and in cardiology, and I was as yet undecided. And I was on the Hammersmith medical rotation, so quite a prestigious medical rotation at the time, and I was very lucky to land a job as what was called a senior house officer. That's a sort of a certain stage of junior doctor training. And I got my job here at the National Hospital, and I absolutely fell in love with neurology, and cardiology fell to the wayside.
Whose team were you on when you first came?
So you rotate round a few different teams.
Yes.
I worked for Mary Riley in the peripheral nerve and the muscle team, and her other colleagues. I worked in the headache team, the epilepsy team. In fact, I had quite a long stint here, and had the benefit of really experiencing a lot of the different subspecialties in neurology, and absolutely fell in love with it, and there was no going back.
Fantastic. And you've been here ever since, as it were?
I have worked my way up as a junior doctor.
Yes.
I did a PhD here, my higher specialist training in neurology, and then, landed a consultant job here, and I was very fortunate to have to land that. So
That's exciting, isn't it? So tell me what you generally do. So what sort of patients are you seeing? What sort of diseases do they have? Where's your real leaning? Where's your expertise?
So neurology is a very clinical specialty, and it really benefits from neurologists keeping in touch with what's called general neurology. That's the ability to see, recognize, manage and treat people with any form of neurological condition. Because when people present with neurological problems, be that movement disorders, headache, other problems, sensory problems, walking problems, they nor their GP is aware of what subspecialty in neurology that falls into. So it's really important that a neurologist has the ability to recognize all aspects of neurology. Having said that, it's really important and fascinating to be involved in a subspecialist area of neurology, and my subspecialist area is movement disorders. So movement disorders is or encompasses a group of conditions, things like Parkinson's, tremor, dystonia, and other types of problem where primarily the brain's control of movement goes wrong.
Yes.
So I have expertise in being able to diagnose that and treat it appropriately depending on the condition.
And how do you identify one from the other? Because, essentially they would all present or have similar features, don't they? So what's the differentiator between them, and how do you do that?
So that's right. But neurology is and has always been a very clinical specialty. So we've seen huge advancements in things like imaging and other technologies. And yet, as I've said before, the clinical aspects of it, taking the story, a very nuanced approach to hearing the story from a patient, asking just the right questions, and then examining the patient is really what we need to decipher the sort of problem that's occurring, we may then be left with one or two possibilities that we use tests for example, scans or blood tests or other specialist tests, to then distinguish between those one or two possibilities. But that ability to see a patient, to examine them and have a very sort of honed in eye on identifying the problem is really key to the subspecialty.
And it must be also just the wealth of experience that you acquire being in Queen Square, but also collaboratively with your colleagues.
That's absolutely right. We have, over the time I've been working as a doctor, and then within the realm of neurology over the last 20 years, I've seen a huge movement towards a much more multidisciplinary approach to seeing people, patients, and treating them. And it's this very collaborative approach that helps us to learn, to develop, and to sort of provide the very best care for our patients.
Fantastic. We were talking earlier because you've just come from what's called the Grand Round. Tell us all about the Grand Round, because it sounds very archaic, I have to say.
Well, it is archaic in the sense that it's been going on for a very long time, many decades. At Queen Square, the Grand Round is eponymously named after Sir William Gowers, who was a very famous British neurologist at the turn of the 19th century into the early part of the 20th century. A Grand Round is really where a patient is brought in to a big lecture theatre, and the lecture theatre is populated by neurologists like myself, neurologists in training and students, and one of our staff then hears the story from the patient, examines them in front of everybody, and then once the patient leaves, we discuss their case, and we discuss that in great detail. It's a brilliant way for us to all be exposed to unusual cases. It's a phenomenal forum for us to learn and develop and to discuss cases amongst ourselves. The Grand Round still happens in many places around the world within neurology and other specialties, but I think here at Queen Square it's still very special in the way that we involve people and patients in that process, and they actually come physically to the lecture theatre.
It's extraordinary, isn't it? Because I would imagine, William Gow, you're right, I think he died in 1915, didn't he? So it must have to be 100 years, doesn't it, that this process has been happening?
That's right. It's been going on for a very long time, and it's really steeped in neurological history.
Yeah.
I mean, there are photos of Charcot at the Salpêtrière, undertaking grand rounds with all the other neurologists he trained and those who worked around him. So it's something that does happen in a number of big neurology centres, and we're obviously very fortunate to be in one of the great centres of neurology in the world, and it's a very important part of our weekly programme.
How fantastic! Did Queen Square start it? Do you think is it a tradition? Queen Square started?
I think we'd like to think that.
I'm sure it is. And other patients that you see, what sort of, we talked about sort of scans and blood tests. Is there a genetic element, do you think, in some of the conditions that you're seeing? And are there now a lot of phenotyping, blood tests happening? What sort of developments are in those sort of diagnoses?
Yeah, that's absolutely right. That's right, Jodie. Genetics have come a very long way, and we are now able to perform very sophisticated genetic tests. Going back 20, 30 years, or not even that long, 20 years ago, when I was training as a junior doctor, we would see people presenting with certain neurological problems, and we would send off tests for specific isolated genes. Right. That's certainly no longer the case, because the way somebody presents, meaning their symptoms and signs, doesn't always match up perfectly to a single gene. And sometimes a certain neurological presentation, for example, a tremor or some other movement abnormality, can map onto a number of different genetic causes. And likewise, one gene can have a number of different presentations. And so it's very important for us to have a much more sophisticated, rapid turnaround of genetic testing rather than just sequentially testing one gene after another. Yeah. So we now are able to test the whole genome, and we're able to test big panels of 70, 80 genes in one go that are candidate genes for the way somebody presents.
And the results of which I therefore would suggest that it then targets your treatment. It makes options, this is going to work because it's that particular
genetic. Yeah, genetic testing is really important because it fundamentally gives us an answer. In some cases, of course, many of the cases we see are not genetic and they are what are called acquired conditions. But in those that are genetic, we then have a definitive cause, and it means we can stop further unnecessary tests. It might mean that people can enter clinical trials, which are really important, targeted at specific genes. It may mean that we have a specific treatment for that gene in a few cases. It also gives us and the person in front of us with the genetic condition a really strong, clear idea of what the future holds.
Yes.
And it also helps us in terms of family planning and also how it may affect other family members.
I hadn't thought of that aspect, actually. You're right, because if there is a genetic element, then people are making decisions that, do I want to carry this gene forward, or do I want to have children or whatever the case may be? And what is my life expectancy, and what can I do now to change?
All really critical questions.
Yeah. So and you not only sort of the gene research and stuff. What other research are you involved in? Because you are a part of your job and your role is doing academic work. Is that right?
So my work day to day and week to week is predominantly clinical. So that means most of my work involves seeing people, making diagnoses and treating them. I am very much interested in research, like many of my colleagues are here at Queen Square, and my research is predominantly clinical, meaning I'm the principal investigator in a number of clinical trials within movement disorders, and I run those trials here at Queen Square. I'm also involved in other types of research, which are clinical research in a lab, so testing patients. That may be forms of, so examining patients or undertaking electrophysiological tests.
Right. Mm-hmm.
So that stemmed from my interest during my PhD, which I spent 3 years investigating a certain type of tremor and the circuits in the brain that were important in generating that tremor. We used techniques such as examining the patient, but also using electrophysiological testing of the brain to map out circuits that may be responsible for that tremor. And that's a sort of research that I still am interested in now.
Fantastic. And what do you see, what's your ambition in the future using that research to translate that into a clinical setting? What sort of breakthroughs do you think you're going to see? What do you want to see?
So I'd really like us to see better ways of differentiating certain types of movement disorder using different approaches to diagnosis and using very specialist testing and movement monitoring to be able to distinguish between different movement disorders. I'd also like to see us translate that work into the clinic and being able to provide new and novel treatments, and that stems from my interest in running clinical trials.
And do you think that also is going to become a really personalised treatment? Using the blood tests, and for other diseases, there is that very personalised, isn't it? It's unique to me treatment. Is that the ambition? That has to be the future.
That's absolutely right, Jodie. And in fact, that is already something that happens. If I look back and I think of all the people that I see day to day in my clinic with essential tremor, with Parkinson's, with other movement disorders, although these individually are common conditions and there are common threads about how we treat people with these conditions, every single journey for every single person that I see is different. And every single one is unique in the way that we together, decide on treatments, which treatments and what combination of treatments we use. And that's very specific to that person's journey and their needs.
The prevalence of tremor and the patients that you see, the type of tremor you see, is it increasing? Is there do you think, any environmental factors causing, increases, or is it stable?
I think that the incidence, I've just undertaken a study looking at the prevalence of essential tremor both in the UK and also in Germany. This was a sort of population-based study, and we have seen a significant increase in the prevalence of essential tremor. It's quite difficult to understand why that is. There may be environmental factors. There may be factors whereby people are beginning to realize that there are now treatments available, and therefore they're seeking a diagnosis. Indeed. And so, the pickup rate is increasing. But other conditions like Parkinson's disease are also well known to be increasing in their incidence or in their prevalence. And again, it's very difficult to really understand why that is. I mean, we've got an aging population that might play a part, but there may be as yet undetermined factors that are sort of playing into that increase in prevalence.
It's interesting, isn't it?
Yeah.
Well, thank you so much for joining me today. I appreciate your time.
Thank you so much, Jodie.